Hi, it's Peter Amenta from neurosurgery. We're going to talk about external ventricular drains. So just a short overview to begin. We're going to look at cerebrospinal fluid and the three processes that are most important to consider. So the formation, circulation, and absorption. Then we'll talk about hydrocephalus, which is the most common reason to place an external ventricular drain. And then we'll cover the actual procedure of external ventricular drain placement and then maintenance of the drain in the ICU. So there are three key points when you think about the spinal fluid. It's how is it formed, how is it stored or circulated, and then how is it absorbed. So if you look at formation, we'll just begin with what the spinal fluid is. It's clear, it's colorless, it's synthesized by the brain and the choroid plexus. It provides buoyancy to the central nervous system, so the brain and spinal cord float in the fluid. And it acts as a buffer or protector of the central nervous system. It's a shock absorber so that the brain doesn't just rub against the skull and the dura. It has this protective envelope around it of fluid. And in an adult, about 150 cc's of spinal fluid are circulating at any given point in time. There's 25 in the ventricular system, and there's another 125 cc's in the subarachnoid space. And over the course of the day, the brain will make about 400 to 600 cc's. And that means that you turn over your entire volume of spinal fluid about 4 to 5 times a day. 70% of the fluid is made, like I said, in the choroid plexus, which is a specialized structure within the ventricular system. And there is some spinal fluid made from other structures, but the vast majority and the most important is made by the choroid plexus. Once it's made, it then has to circulate around the central nervous system. And so the easiest way to conceptualize it is the step-by-step process. So it's starting in the lateral ventricles, which here are denoted by the red arrow. This is the right lateral ventricle and the left lateral ventricle. And the fluid has to exit those ventricles and make it to the third ventricle. And to do that, it goes through the foramina of Monro. And those are the interventricular foramina. From there, it enters the third ventricle here, which is the white arrow. So the foramina Monro, the blue arrow, the third ventricle is the white arrow. And in a normal patient, the third ventricle is small. It's like a slit. And the fluid goes through that third ventricle and then enters what's called the aqueduct of Sylvius, which is here, or the cerebral aqueduct. It's this tiny dot in the brainstem. It's a little tube that then connects the third ventricle to the fourth ventricle, which is denoted here by the green arrow. Once it gets to the fourth ventricle, it has to exit the brain. And there it goes through the foramen of Magendie in the midline, or one of the two foramina of Luschka off to the side, one on the left, one on the right. It enters the subarachnoid space and then circulates up over the brain or down into the spinal canal. Once in the subarachnoid space, we then have to absorb the spinal fluid. And this is primarily done through what are called the arachnoid villi. So we have arachnoid in the brain. It's one of the layers of the meninges. And in certain areas along the superior sagittal sinus, transverse sinus, it pushes into the sinus, which is the venous sinus, the venous system of the brain. And the spinal fluid goes into the venous sinus and then outside of the head in the circulatory system. And that's how the brain gets rid of the spinal fluid. And under normal circumstances, the production of spinal fluid and the absorption of spinal fluid are equal, so that we always have that 150 cc's at any point in time throughout the day. And this is an artist's depiction. I just took it from the internet. So we'll follow the pointer. So here's the lateral ventricle. This is looking through the side, the sagittal view, so looking through the side of the brain. This is your lateral ventricle, this choroid plexus, which makes the spinal fluid. The CSF, only way out of the lateral ventricle is to go through the foramen of Monro. There's one on each side. They're paired. They both enter with a single third ventricle. Then from the third ventricle, the spinal fluid has to get out somehow. So the only way out is through the aqueduct of Sylvius, the cerebral aqueduct. That connects to the fourth ventricle. And then here you see the foramen of Luschka, the foramen of Magendie. That's how it gets out of the brain into the subarachnoid space. It circulates around the brain and then goes through the arachnoid granulations into the venous sinuses, and the venous sinuses take the spinal fluid with the circulation outside of the central nervous system, outside of the head. And hydrocephalus is defined as the accumulation of any abnormal volume of CSF in the ventricles. And it's a complex problem. There are a lot of underlying causes. There are a lot of ways this manifests. But to think of it as any abnormal volume of spinal fluid. And the way we break down hydrocephalus is really two categories: obstructive hydrocephalus and communicating hydrocephalus, and we'll go over those. So obstructive hydrocephalus is the physical blockage of spinal fluid circulation and blocking it as it flows through the ventricular system. So there are multiple causes. It can be a tumor, and tumors can do it directly or indirectly. It can be hemorrhage, so any kind of hemorrhage, whether it be from trauma, hypertension, aneurysmal subarachnoid hemorrhage. If blood gets into the ventricular system, it can block the flow of spinal fluid. It acts as a plug. And then intraventricular scarring is another way. So people that have bad meningitis, they have scar that forms in their ventricular system, and it acts as a physical blockade to the flow of spinal fluid. And there are other ways, but those are some of the more common ones. And obstructive hydrocephalus can be an acute life-threatening emergency. And just here are some examples. So this was a patient in the ICU maybe about 6 weeks ago. If you look at the middle picture, this is the hemorrhage. This is in the thalamus, called the pulvinar region of the thalamus. It's a hypertensive hemorrhage, and it broke through the brain into the ventricular system, and it's called casting or blocking of the third ventricle. If you look below that level into the fourth ventricle, you have casting of the fourth ventricle, and you also have pretty much casting of the right lateral ventricle, less blood in the left ventricle. So basically you have obstruction at multiple levels. The spinal fluid can't get around the blood, so it builds up in the ventricular system, and you can see the ventricular system is big, and so a ventriculostomy was placed. This is a patient I operated on probably about 5 months ago at this point. This asterisk is over a big meningioma in the posterior fossa, pressing on the brainstem and pinching off the fourth ventricle. And above that, so the lateral ventricles, you see the buildup of spinal fluid, very, very enlarged ventricles. And you actually see swelling in the brain that's called transependymal flow. The spinal fluid has nowhere to go, so it goes through the ventricle into the brain and causes a problem. And what's interesting is when this patient was elderly, probably had this tumor for a very long time, never had medical care. Even if you take out the source of obstruction, oftentimes with long-standing hydrocephalus, the patients never get over the hydrocephalus. So here she is, after the tumor's out, the ventricles remained rather large, and she ended up needing a shunt for permanent CSF drainage. Here's another example of hydrocephalus from a tumor. This is a colloid cyst. It grows in the third ventricle, so it blocks the flow from the lateral ventricles, and you can see the ventricles are enlarged here. Once you take the cyst out, you remove the obstruction, and the ventricles come back down to a more normal size. Then communicating hydrocephalus. So this is if the spinal fluid is able to get out of the ventricular system, but it can't be absorbed. So this is usually at the level of the arachnoid villi, those little protrusions into the sinuses. And anything that causes scarring at this level will cause communicating hydrocephalus. So meningitis, aneurysmal subarachnoid hemorrhage. If the meninges are involved by tumor, something called carcinomatous meningitis. And even people that, usually it's multiple brain surgeries, but people that have had brain surgery, once you open up the head, if there's significant scarring at the level of the arachnoid villi, they may not be able to drain spinal fluid, and they'll develop communicating hydrocephalus. Here's an example of that. This was a patient we treated here probably about 5 months ago. She had a ruptured aneurysm, so you see the blood, the subarachnoid hemorrhage in the cisterns. Really, there's no obstruction in the ventricle, but because of the irritation of the bleeding, there's some other processes involved. The brain doesn't absorb the spinal fluid. And then you see later on, a couple weeks later, even though the blood is resolved, she has very large ventricles, and she needed a ventriculostomy and eventually a shunt. And once the shunt was placed, she developed normal-sized ventricles, and she improved greatly. So why do we place a ventriculostomy? Well, we can place it as an intracranial pressure monitor. It has the benefit of treating increased intracranial pressure through the drainage of spinal fluid. So if the pressure is up, you not only have a monitor to show you that, but you can drain spinal fluid to hopefully bring the pressure down. And just like we talked about then, the treatment of hydrocephalus or the buildup of spinal fluid. It's a temporary means by which to divert spinal fluid out of the head until either the patient recovers the ability to absorb spinal fluid, you remove the source of obstruction, or the patient gets a shunt and permanent spinal fluid drainage. So the placement of ventriculostomy is one of the most common neurosurgical procedures, certainly in terms of emergency or emergent neurosurgical procedures. It's probably the most common. Ingram and Campbell in 1941, they weren't the first to place a ventriculostomy, but they basically gave us the modern version of ventriculostomy by preventing overdrainage, decreasing the risk of infection, coming up with the appropriate tubing that could be secured to the scalp so the drain wouldn't pull out. And let's go over then the placement of the catheter itself. So the equipment, you need a razor, so to shave the head, to remove hair from where you're working. You can use any kind of prep, so ChloraPrep or betadine prep, a marker and a ruler to mark out the landmarks where you want to start your incision, start your drilling, and place your catheter. Face mask, sterile gown, and gloves to protect you and the patient. It's a sterile procedure. You need a cranial access kit, which basically has almost everything you need, including the drill and the scalpel. The drill is called a twist drill. You connect the drill bit to the drill and then use just a drilling motion to make a hole in the skull. The ventriculostomy itself, and then you want to secure it to the head with sutures or staples and a sterile dressing. And then once everything's done, then you hook it up to the collection chamber. You need the neurosurgeon or the neurosurgical resident, or some of our APPs also place ventriculostomies. It's helpful to have an assistant, someone who can lean underneath the drapes and hold the head, because as you're drilling, the head can kind of toggle back and forth and make it a little more difficult. That person's not always available. And then, of course, nursing, to monitor the vitals of the patient, administer sedation, potentially help with holding the head and just kind of helping the surgeon or the resident place the catheter and help with the monitoring of the patient's vitals. In terms of preparation, you want to shave the head, you want to mark out your starting point, prep the head. For me, I like to put the patient to sleep, intubate and sedate. I think it removes some of the confounding factors. Some of our patients have taken various substances, and that's leads to confusion or a lack of cooperation. Some patients have ruptured aneurysms, and you don't want their blood pressure spiking during the procedure. I think it's just easier to control the environment and place the catheter, but not everyone goes by that, and conscious sedation is often done. In terms of the relevant anatomy, there's some surface landmarks, and there are multiple places you can actually get a ventricular catheter into the ventricles, but by far Coker's point's the most common. Everyone's measurements are a little different. Basically, whatever works for you and gets it in the ventricle is what you go by. For me, it's 10 centimeters posterior to the glabella, which is this bony ridge right above your eyes in the midline, so 10 centimeters back, and 2.5 centimeters usually off to the right. We go to the right because your right frontal lobe is non-eloquent and non-dominant in the vast majority of people, and if there's a complication, God forbid, you're having that complication in non-eloquent brain. You advance the catheter about 6 centimeters. That's usually the distance to the right frontal horn. When you're aiming for two intersecting lines, so a line through your trachea, which is this cartilage bump on your ear, and through the mid-pupillary line, so in the midline. And where they intersect, that should be the foramen of Monroe, and that's kind of your landmark. You want to aim slightly medial and slightly posterior, and the goal is to what we hit the frontal horn of the lateral ventricle. And when you hit the lateral ventricle, usually the person putting the catheter in feels a drop-off in resistance. So you're going through the solid brain, hitting the fluid sac, and then all of a sudden you'll feel like a pop, and the spinal fluid will come out. It's a surgical procedure. There are complications. There's infection or ventriculitis. There can be catheter hemorrhage, so a hemorrhage around the catheter. Usually it's clinically insignificant. It can be significant, even require surgical resection. You can miss. It's a blind procedure using scalp and skull landmarks to hit a fluid sac in the middle of the brain. You can miss the ventricle. You can overdrain. The catheter can be blocked by blood, air, debris. An important thing is to check for is the leaking around the catheter once it's in, and that can lead to infection. And then, of course, patients, they move around, they can fracture the catheter, they can pull their own catheter out, which can be disastrous, particularly if the patient's on blood thinners. So the catheter should be secured to the head. You want to keep the site clean and dry. You want to check it on a daily basis to make sure it's not leaking. You want to look at the pillow, make sure that there's not fluid building up on the pillow. Sometimes you see that. You want to remind the patient that there's a catheter in their head. And if the patient's uncooperative and they need to be restrained in mitts, I think that's okay, particularly in patients on blood thinners. You don't want that catheter coming out. You don't want to have to put a new catheter in. Once it's in, we want to follow the intracranial pressure. We want to make sure that the collection system remains level with the ear. I think we have the lasers here to do that. We set the drainage for a specific pressure, and we should log the volume of CSF drained every hour. And at least once a week for me, I would send CSF to make sure that there's no infection brewing via Grand staining culture. I like to keep these in no more than 14 days. I think the longer you keep them in, the higher the risk of having a complication, whether it be infection, the patient pulling it out, etc. And then you want to remove it, or you want to put a shunt in. The clamp trial, so when the ventricular catheter is clamped, we don't drain any CSF. You want to monitor the intracranial pressure. You want to follow the patient's exam. Do they get sleepy? Do they deteriorate from a neurologic standpoint? Do they get headaches? And does the CT show that the ventricular system is enlarging? These would all be signs of a failed clamp trial. And at that point, you would have to convert the patient to a shunt and permanent drainage. I think that's my last slide, and I appreciate it, and thank you very much.